This is Heart Rhythm TV. We have a very special interview and episode today featuring the article by Professor Yan Yao coming from Fuwai, Beijing, with commentary from Thomas Deneke, talking about the success of VT ablation without background ICD therapy. This is a hot topic. We've seen signals of this from Europe, looking at a relatively low risk of sudden death in patients that do not have a background ICD therapy. And this is a good one for us to dive into. Professor Yao, congratulations on being selected as a featured article, and thank you for joining Heart Rhythm TV.
Thank you. My pleasure. So, first of all, the reason we want to publish and share these experiences is because if we look at the whole world, except the US and North America and West Europe, the rest part of the whole world, billions of people, they cannot afford an ICD. So we know the guidelines, we need to give them the ICD, but most of them they cannot afford. I started to do this job more than 24 years ago. Then at that time, I remember there are only about 100 or 200 ICD implanted in whole China, with more than 1.4 billion populations. Now, we start to do that work by trying to do a catheter ablation to deal with this VT, whatever, ARVC, ischemic. So actually, things get much better now. So now, last year, China implanted more than 16,000 ICD, but still it's a small number compared with Germany and the US. I think even in Europe, if you compare the data between different countries, I guess in year 2019, Germany implanted more than 400 ICD per million populations, while the UK is below 100. So that's the reason we have to do this work.
Well, tell us a little bit about the population you studied.
Okay, so this is actually a retrograde, data. We totally have more than 250 cases enrolled. After we, exclude those other, for other diseases, we finally have about 220 cases, and half of them did not have the ICD implanted. So they surely rely on ICD, except the economic reasons. Many of them, especially those who are relatively younger, they do also suffer the culture or society pressures for this kind of implantations. So they choose to rely on the catheter ablations. I think the progress on the high density mapping is an important work done by Roderick Tung and others like Dr. Logami's, strategy. So we found they provide more confidence for us to perform such ablations, especially for those with less than 2 morphology of VTs. And also other progress, which is very important, is epicardial approach.
So this is worth us highlighting, and obviously we're going to involve Dr. Deneke in the discussions who talk about the editorial. You and I both know, because we've collaborated a lot with PAUSE trial, and we even had a registry arm that did not have defibrillators, because we know that sometimes there's incomplete reimbursement, right, in China, which is not thinkable in the United States. We know there are potentially cultural biases of not wanting to accept a defibrillator. Can you just highlight again what the major issues are when you discuss with the patients in China about defibrillator, and what the mechanisms of their refusal are, what the main reasons are? Because I think that's very important as we have a global discussion about different cultural attitudes and influences.
It used to be very difficult, and not even a chance. You mentioned about choose of ICD, but with rapid economic growth, now it's much easier for us. We now always recommend them to do both. So say if we do both and you observe at least for one ICD, if there's no recurrence, you may feel more confident to not to replace it when the battery is out. So much easier than before. Also, the country established a national-wide reimbursement system, so which covers almost everyone, make us much easier. But I do know our neighboring countries such as India and Vietnam, others, with huge populations, situation is much more like ours 20 years ago. So that's still something. I think it's difficult for doctor. Yeah.
And Professor Yao, I know that your center has also evolved to more epicardial strategies. Can you take us through a little bit about whether you think there's a bias when you think there's no defibrillator, that you have to do more scar modification to try to make sure you increase the efficacy? And what was the reason why there might be more epicardial utilization than before?
Okay, very good questions. In fact, we started this ablation for VT more than 20 years ago, but we adopted a new progress, partially due to also your work. And you come to my lab, show your ways, and we did prefer more activation mapping due to we use a non-contact mapping before. But you showed us how important the high-density mapping is. By doing that, we found, combined with the epicardial approach, in this cohort, we noticed that those with both endo and epicardial approaches seems like do show better results, and also combined with the high-density mapping for the substrate modification. Also, this is confirmed by VISTA trial and other trials from the Barcelona, Spain in year 2016. So I think we need to do more work on this.
Dr. Deneke, there's 2 sudden deaths in this cohort, of over 100 patients, which puts us less than 2% for sudden arrhythmic death. And the overall mortality was around 5%. Is this something that should have a threshold effect? What is an acceptable rate of sudden death? If we think about HCM, long QT, the general risks is 5% at 5 years. And this really falls within that, if not lower. What's acceptable as a field if we were to actually explore this prospectively?
Well, Rod, this is a very, very tough question because, with every intervention, you will find patients who will fall out of the scope of saving them. And so I would tend to agree. I would put it this way. This is a very, very low number of sudden arrhythmic death incidents. And I most probably would think that 1 or 2% in this time range is very, very favorable. But let me try to make a different point as well. We're talking about reducing the risk of arrhythmogenic events in this cohort on the one hand, but I think, and that's what we've learned also from other ablation trials, is that actually most of these patients do not die from recurrent ventricular arrhythmia, but they die from progressive heart failure or progression of their underlying structural heart disease. And this makes me call for a combined multidisciplinary effort in all these patients. VT is not a EP disease. It's a general cardiology disease, at least. And we need to combine heart failure specialists, device specialists, structural coronary and valvular specialists all into one set of team that needs to address these patients. I think that has become clear over the last years, and this is just another side effect that was seen in this wonderful study. On the other hand, I really think that the incidence of arrhythmogenic death is very, very low, as also in patients who have, for example, tolerated VT in ischemic populations. we don't really know much about the non-ischemic population so far. As you know, all the data we have from larger sample sizes is on the ischemic population. But I think there are many signs available now that actually we need to evaluate the risk of arrhythmogenic death in these patients with today's efforts that we have for heart failure treatment, medication, ICDs, VT ablation. And so I think what the colleagues just need to emphasize is that we need a study, a controlled study evaluating this specific topic, even though I guess no ICD company will fund that then.
Those are excellent comments. There's a couple things that I want to make sure we highlight for our viewership. Number one, the recurrence rate was still about 40%, which tells you that a lot of patients that recur don't die suddenly, right? So it's not that you need to get an ablation to the point where every single recurrence is synonymous with a mortality. And we understand that even from primary prevention, that an ICD shock is not a surrogate for death, because you have way more shocks than you do have for death when you think about control and primary prevention. The other thing to take into account is, obviously, as you point out, and Dr. Yan says, this is retrospective. And even when we did the pause registry, we recognized there is going to be some bias towards somehow accepting patients that don't want to have it, that maybe they are healthier, maybe they're younger, maybe their ejection fraction is a little bit better. But what is different about the European experience is that Mori and Zeppenfeld and things that you've been part of, Thomas, is that it's qualified by tolerated VT and ejection fraction of over 40. But this was really an all-comer study. And I don't know if Dr. Yao Yan, if you have a feeling that maybe if the EF is lower, you're going to push harder or really force, or if it's more tolerated, it's okay. Do you believe there are some of these biases as doctors discuss ICD?
Yeah, I totally agree with you two opinions. And we, based on our prior research, Pulse ICD, which is such excellent trials led by you, we think we probably need to do such a new trials of focus on these issues, provide more evidence. And for this, if we want to do that, we probably need a better designs and consider the progress in therapy to the ischemic heart disease. We need to consider this SGLT2, the new applications, and all these new, PCI or whatever, those new things. It seems like they significantly improve the long-term results of this progression of these patients. For example, in my hospital, we got these PCI patients in more than 25 years ago, only about 200 cases a year. Now it's about 20,000. 25,000 cases, PCI. But the patients who come to me for ablation is still very low. I think it's majorly due to this progress for the drugs and the PCI and other therapies, which improve their, prognosis. So we should have our trials to consider all these, relative issues together.
Yes, and for the viewers again that may not be as familiar with the practice of EP in China, with such an expansive geography, you do have the very tertiary quaternary centers. So many patients from the villages that can actually then come in and get referred to Fuwai Hospital, to some of the primary areas, they are self-selected to have more tolerated VT. We have observed that you're going to have less, because those that are out in the villages, they may not have access to public AEDs and other things, they don't make it. So it's very possible that there is a referral bias that those that come, at least in China, because of just the vast expansive nature of this country, are pre-selected already. There's something different about them. So Dr. Deneke, do we want to do a randomized trial in Europe and China? It seems like there's certainly an appetite for that.
I hope in the US as well.
There may be some ethical IRB issues with it, and that's the question: is how do we what's the narrative for this? You know, because this is a secondary prevention population. This is what I love about the discussion. Primary prevention, we know it's a very wide net. Maybe 80% of patients never even receive a life-saving therapy with primary prevention ICD. This is secondary prevention ICD being modified by ablation, which has mortality implications, right? But I think it'd be great global. But how do we do it, Thomas?
No, I completely agree. And I mean, there are two sets of patients as well. So this is, if a patient like that would come to a hospital in Europe or within the US, they would have a class 1 recommendation for an ICD. And that's why if you want to change this or think there is indications that there may be, that the risk may be much lower, we need randomized trials. I'm 100% sure we need trials for randomization. On the other hand, we have to select the patients very, very carefully. So ischemic population is definitely the best studied population of this. So we need to include most of these patients. And in the current study that we're discussing, I think at least 30 to 40% of the patients had hemodynamically non-tolerated VT initially, but some of them also had tolerated VT. So we need to identify those patients that are most probably those who would have a clear class 1 recommendation for secondary ICD prevention. And then we need to randomize them either for ICD or for ablation. And we need to identify these cohort, and we need to make sure, on the other hand, that all the other risk factors that they have, heart failure, progression, needs to be optimally treated to make the groups comparable.
Well, I think if we're going to be very evidence-based, one justification in the United States would be that we know that even in secondary prevention, you know, SIDS and CASH were negative trials. Then if you take a look at AVID, the subgroup of EF of greater than 35 did not have survival benefit. So maybe the justification to an IRB could be that it has to be an EF of over 35% and then randomize that from ablation to ICD. That would be exciting for PAUSE too, Dr. Yao.
Yeah, I agree. We probably also need to combine some new biomarkers like NT-proBNP, which we use a lot for clinical practice in recent years. So we probably can define these patients more precisely.
Mm. Yeah. So maybe a class 1 or New York Heart Association 1, 2, look at BNP and maybe the heart failure status. Although one could argue with more advanced heart failure status, they may have a shift of the mortality to heart failure and not arrhythmic. Mm. So I think that's also a good one to discuss. Well, I want to congratulate both of you, Dr. Deneke for a great editorial, Dr. Yao for showing the world these data from China. Clearly they are provocative, but clearly they're retrospective. This is hypothesis generating, but it does support some of the European experience as well. And I think this is an exciting topic for all of us to talk about. And thank you very much for joining Heart Rhythm TV.